hospital, and he is always on the second call in the city of Gandhidham, who is helping to all our junior and senior colleagues in the city of Gandhidham in the term of emergency, obstetric emergency. So his area of interest is lifestyle modification to help patient coming out of that disease naturally. He has served as a IMA secretary in the year 2013, and he has served as a president in the year 2014, 15, 15, 16, and 1920 of the Gandhidham OBGY Society. Now, Bhavik, I invite you for your talk.
Thank you very much, sir. I hope I am audible to each and everyone.
Yeah.
Yes, sir.
I would like to thank Dr. Meenakshi Madam, Dr. Deepesh sir, and all the office bearers of Foxy for giving me opportunity to share my ideas about counseling and obstetric emergency. Let us start. An emergency is an occurrence of serious and dangerous events developing suddenly and unexpectedly, demanding immediate attention and interventions to prevent worsening of the situation. An obstetric emergency means related to obstetric, that is pregnancy or the delivery. The common obstetric emergencies that already been discussed is APH, PPH, eclampsia, uterine and horizon rupture, amniotic fluid embolism, postpartum collapse, cord prolapse, shoulder dystocia, and so on. In a cross-sectional study during October 2016 and 17, it was observed that health education to pregnant women about importance of accessing maternal health services, early ANC booking, regular health checkups, identification of the high-risk pregnancy, simultaneous counseling, timely referral whenever needed, availability of fully functional first referral units and transport facilities for the same will really help reducing such obstetric emergencies and the morbidity mortality coming out of it. The availability of skilled medical personnel around the clock in the first referral units is the need of hour. The doctor-patient relationship is really central to the practice of medicine and is very essential for delivering good quality of care to them. And the counseling skill remains the core factor that does the function of cementing the doctor and the patient bond. Counseling is an interactive process between the doctor and a woman along with her family. It's not about a patient, it's about patient and relatives, where information is exchanged and support is provided to them. And the main goals of counseling are creating a good personal relationship with patient and the family, facilitating exchange of information to them, and including patients in decision making. Woman and her family can take good decisions and they can design a plan and take actions accordingly. Why should we counsel? It is really very important to share information with women and their families about the early detection and recognition of any danger sign that is coming out during the treatment of a patient. The counseling to patient and the relative is very necessary to avoid medical legal litigations and violence. If we are good at counseling, we can prevent maximum amount of the medical legal litigations and violence, because satisfied patients are less likely to lodge complaints and rather become advantageous for doctors in terms of less work-related stress and reduced burnouts. The common types of communication is written, verbal, and non-verbal. The verbal form is only the words that you speak, and I tell you that it delivers only 10% of the information to the person in front of you, that is patient or the relatives, while the 90% of your information is being transferred to them by the other things, and that is non-verbal things. What comes under non-verbal communication is the touch, the time punctuality, whether you allow them to wait, your gestures, your body language, your facial expression, whether you do a good eye contact with them, how you are dressed, and what is the tone and the rhythm of your voice, how stressful you are looking. And the written part includes the consent part. If time permits, we'll see that also. Effective communication skill requires a good eye contact with the patient and the relatives, an attractive body language. We should stop in between. We should not counsel the patient, and we are not stopping for a minute so that the relatives can ask. We should stop in between counseling our patient or the relatives. We should check for any information they want. We should have a little smiling face. And at the end of the counseling, we should summarize all the things that what really we want to tell them. We should encourage them if they want some more information, and we can ask for some questions if they have. A good clinician should be well dressed, well groomed. He should breathe and he should be ordering properly. He should be knowledgeable, confident, but not arrogant. He should show empathy and care. And ultimately, the patients are human beings, and we have to understand this. And we have to show our empathy towards them. We should be a good listener. It should not be like, if patient or the relative have some questions, stop and try to understand, try to listen what they are saying. And we should be positive. We should tell good news. Sometimes the whole obstetric emergency has been dealt, and we find that many wrong things, many complications have happened. But out of the complications, there are some positive hopes. There are some positive points. Like if at all there is stillbirth, what we can really say that the good thing that has happened is the mother is very much alive with us and she is doing very well. So such small positive words will help you boost up, will help relatives to come out of the shock that at least something good has happened to them. So we need to give them a good hope in each and every case. If we all need to do wonderful counseling, then what is the problem in doing good counseling? And some of the challenges that we face during good counseling is time constraints. That we'll see what is that. Then there is language. Sometimes we don't speak. We try to speak in our own language, and the person in front of us really don't understand. And it happens with many of the Gujarati people that they start counseling the Hindi or the South Indian people, and many a times they say that we don't really understand Gujarati, we neither understand Hindi, and there comes the problem. Sometimes we start counseling the patient in a very big room, and there are so many people around, and there is noise. Sometimes we counsel people from a 20-feet distance, again, that causes a problem. Sometimes there are two relatives asking too many questions, and you find difficulty counseling them. Again, you have to take care of that. You have to take consent also. It's not about just counseling them, it's about taking consent as well during emergencies. You have to take care of anesthesia and related risk. You have to take care that during your counseling or after counseling, there should not be any violence. Again, sometimes there are two patients simultaneously falling in obstetric emergency, and you have to take care of both. Again, that remains a very troublesome thing. We have to see that mother comes the first. We have to see that what is good for mother will be ultimately good for baby as well. And we have to always see that if mother can be saved easily, we should do timely delivery of the baby as well whenever it is possible. Time constraints. Usually what happens, as we have seen in previous slides, that during obstetric emergency, we have very limited time to tackle. We know that some emergencies are so fast to develop that the patient will succumb in minutes in front of you if you don't do anything. In such cases, we think like what to do, whether we should resuscitate the patient or we should go to relatives for counseling. In such cases, we should never waste a single minute. We should do all the efforts that can be possible in the obstetric room or the operation theater to save the patients. And once the treatment is started, immediately we should shift to the relatives to counsel about the situation. We should take enough time for counseling the patient and the families. Sometimes we are overburdened with the work. Sometimes we know that we sometimes think that, oh, this is the 3rd grade or the 4th grade case. The delivery will happen in just a few minutes and the patient will be shifted to rooms in say 10-15 minutes. Suddenly the patient develops complication and then we have a huge list outside waiting in our waiting room. The receptionist informs you, say, yes, sir, there are 15 patients waiting. You think that there is an emergency, there is an elective surgery tomorrow morning. How will you manage all the things? But you need to prioritize all the pending work that is there, and you have to give obstetric emergency the most priority. Now let us see something about consent process. During any obstetric emergencies, consent taking becomes must. Never send your paramedical personnel for consent taking. What happens sometimes, that in some of the obstetricians, they tend to send their staff for taking the consent. And the staff is really not very well in counseling and all, and then they just go outside and tell that the patient is critical and now you have to sign. Then comes the problem, and relatives say, doctor કેમ નથી આવતા, doctor કેમ બહાર નથી આવતા, બોલાવો એમ. So never send your paramedical personnel. Always take individual case concern and not the blanket concern. If you are coming across a case of placenta previa and it gets complicated, take the whole consent of placenta previa. You take a blanket consent for obstetric emergency as a whole. A good consent will save you from future litigations. Now we'll see some points about counseling patient's family. We should always confirm the relatives before starting counseling. What happens many times is we start counseling group of people that is there in front of you, and after 1 or 2 minutes we come to note that these are not the relatives of Bhavnaben, these are the relatives of Ashaben. And then you become frustrated. Again, you go back and out, where are the relatives of Ashaben? So we should confirm the relatives that are there before us, and we have to confirm that you are the relatives of this. If they say yes, then go for the counseling. We should wait for all the available family members to be a part of your counseling. This happens many times during our OPD hours and during emergency times as well, that the moment you start counseling in front with the people in front of you, there are 2 or 3 numbers, half of your counseling over and suddenly they shout, "Uba raho, ena mummy ne bolayao, eni sasu ne samjavjo, uba rena sasra ne bada આવે છે, એ બારે ઉભા છે." So you cannot wait. You cannot counsel the same thing 2 times, 4 times, because it becomes troublesome for you. So you should wait for some minutes so that the whole family members can be available. Again, we have to identify important members of the family. Sometimes there is a mob in front of you of 10 or 12 people. And then you come to note that family members are only 3 out of them. So you have to guide those 3 people regarding decision making about what to do in such cases. We have to explain in the words and language they understand, depending upon their socio-economic class and as well as their educational status. If the patient comes from a very high class, you need to use language. If the patient comes from a very low socio-economic class, you can use some desi words. Use medical terminology when required. Sometimes using medical terminology will help patient and the relatives know that your knowledge is a bit sound. If you tell them this is a very complicated case, અને PPH કહેવાય, આમાં તકલીફ વધે તો obstetric hysterectomy કરવી પડે. Whether patient and relatives really don't understand about what you have said, but they at least know that you know something that is not to them, and this will really help them boosting their confidence. We should judge the behavior of the relatives in front of you in terms of possible future violence. How you can judge that I will tell later. We should calm the relatives and reassure them as much as possible. Emergency, or whenever there is an emergency in front of you, you have to make situations as calm and cool as possible. We have to let them know that the best is being done. We know that we all obstetricians do our best possible in all our patients. આપણે જાન નાખી દઈએ આપણા પેશન્ટ્સમાં. But not just doing it, we have to let patient and relatives know. અમે આ કર્યું, આટલી વસ્તુ અમે કરી ચૂક્યા છીએ. આટલી આજની તારીખમાં આપણી પાસે જેટલી સિચ્યુએશન છે એમાં બેસ્ટ ટ્રીટમેન્ટ છે. If we say such things that આજની સિચ્યુએશનમાં what we have done is the best thing that is possible, relatives will be reassured that no, we are in good hands. There are some steps of counseling process. One is engage the women in interactive discussion if possible. Whenever possible, if the situation permits, the patient is not disoriented, then we should always engage women in also the counseling. You should clearly inform the situation that it poses a problem for whom we have to grade the level of the danger, that is minimum or maximum. Sometimes what we do is we just go in front of relatives and counsel that khatro છે, શું થાય છે. And relatives really don't understand whether the khatro is to mother or to the fetus. We have to let them know that the risk is mother or to baby. And we have to grade the risk, that the risk associated with is minimum risk or grave risk. We have to tell that જોખમ 100% છે, થોડું જોખમ છે, પછી આગળ ટ્રીટમેન્ટ કરીએ પછી ખબર પડે. We have to clearly mention what percent the risk is. We have to guide them about the alternative solutions available. It is not like that what you are doing is best as per the situation. But it is not that what you are doing is the only thing that is available. We have to discuss with the relative that what is currently being done and what else could be done. Feel free to call your second call colleague and anesthetize whenever needed. We should not feel shy कि यार हम बीजा ने बोला उसको तो क्यों लागसे नहीं patient लागसे. If you don't call and the patient succumbs, then they will think the doctor has not done things properly. But if the patient is saved, then they will forget everything. Wow, doctor has done a wonderful job. So always feel free to call for the help. Feel free to keep open the option of referring the patient to the best nearest center promptly whenever needed. If you at all think that this patient, this case cannot be managed at your nursing home, you should take immediate decision with the help of family that this patient should be shifted to a better referral center and this patient will be saved there. We should identify all the information regarding that. આપણે રેફર કરીએ ત્યાં ફોન કરીને જાણી લઈએ ખાટલા ખાલી છે કે નહીં, આઈસીયુ માં શિફ્ટ કરવું પડશે તો ત્યાં ખાટલા છે કે નહીં, whether they are ready to treat such case or not, obstetrician is available there or not, and if at all sometimes the emergency ambulance and everything is required, so we should help them managing these things as well. We should develop a plan together. It's not that only the patient and the relative has to decide and doctors will not do anything. We should counsel them, we should help them making a plan to tackle the emergency in the best situation. We should assist the patient and relatives to decide the best plan possible. We should review and evaluate the situation. In case patient deteriorates after the initial plan, let the family know that the further plan of action is required. What happens many a times that if the patient in say third stage of labor collapses and we find that the patient is a little low BP and the pulse is really increasing, and then we start resuscitation and suddenly patient improves, and then we counsel the relatives like, but if at all after 10 minutes, if the situation deteriorates and you need to do some extra actions, you have to again go back to the relatives, do thorough counseling about what has happened, and take consent separately. So you have taken the consent one time that these things have happened, but if the situation worsens, you have to take consent separately. Keep them updated with time to time about patient situation and the best possible measures being done. If you do this, they will feel like, yeah, doctor hamare sath baat kare. Many times in corporate hospitals, the patient is critical, the relatives are waiting outside for hours and hours together, and they really don't know that what has happened now to the patient, whether the patient is alive, improving, not improving. It should not be like this. We should inform them time to time. Now, as we know that time is really a problem, we cannot waste 15 minutes in counseling. Meanwhile, the patient may get succumb. So what we can really do is we can identify some of the high-risk cases. We can know that these patients can fall under obstetric emergency cases. So we have such time. What happens is such patients come in our OPD. If you are admitting such patients, complicated patients, you can counseling well advance. That look, these many complications may really happen. If something goes wrong, we have to do these and that things. What are those complications? Advanced maternal age, tobacco chewing, smoking cigarettes, alcohol, and medical disorders like high blood pressure, obesity, diabetes, epilepsy, thyroid disorders, heart disorders, asthma, multiple gestation, placenta previa, IUGR, RH, isomnization. Simultaneously, we can counsel that they should do something. In our OPD, you can also counsel that if you want to get avoided from some complications, you should start changing your lifestyle, quit your bad habits, you will start taking medicines regularly, follow. And if you counsel such high-risk patients before admitting them, and if something really goes wrong during your treatment, and that is during delivery or the cesarean sections, the relatives already know that doctor has informed. Doctor has said, and the taklif has really started. So your job becomes little easier if you have started counseling well in advance. We have to inform general danger signs during pregnancy, and many of the obstetricians, what they do is write all these things in their file. File માં બધી નિશાનીઓ લખેલી હોય કે ભાઈ આવું કંઈ થાય તો હોસ્પિટલમાં તરત આવજો. And what are these? They are bleeding from vagina, leaking from vagina, convulsions, severe headache, blurring of vision, fever, extreme weakness, severe abdominal pain, fast breathing, edema feet and edema face, severe diarrhea, vomiting, loss of fetal movements. If patient should be counseled that if something goes wrong, so you should come immediately to hospital so that you can be saved and we can do interventions earlier. Now, something about violence. Department of OBGY reported the highest rate of violence followed by the medicine and the surgery. And the female doctors are more likely to face violence. And what is the common form of violence? And that is verbal violence. Patient or relatives will say this and that, and tamne જોઈ લેશું ને તમારું તો આમ ને તેમ. Verbal violence is the most common form of violence. And in emergency department, 100% of the doctors have reported some or other kind of verbal violence. We should be vigilant. And we have to detect the early signs of possible violence in front of us. And how can we detect? Number one point is staring. If whenever you are counseling the relatives and some of the relatives constantly stare at you with great anger, you can immediately think that situation may get wrong anytime. We have to notice the tone and the volume of the voice of the relatives. You have noticed that during OPD hours or while admitting them, the voice was so soft. And suddenly the tone came. So such tone and volume can easily be judged, and we can assume that something may get wrong. Sometimes the patient becomes too anxious. Sometimes there is mumbling in their voice. Such things, the example that I'm giving, such things whenever happening, so we can judge that the situation may become worse in front of you. And one more beautiful thing is spacing. Relatives start doing things very fast. Fatafat doctor ne bulao, fatafat aam karo, jaldi aam karo, paisa jama karo. Whenever you see that the relatives are trying to be in a hurry, always judge that the violence may occur. Death on table is something that is very notorious and everyone wants to be rid of it. It's really a nightmare. A surgeon is caught at least once in a lifetime in the tragedy regarding death on table. But we have to come out of this, and how we should come out. Breaking bad news is one of the physician's most difficult responsibility, and we have to take multiple things in our mind before declaring bad news to the relatives. What we should do is we should take care of ourselves so that we are not beaten up. Sometimes you go alone in front of your relatives and tell them the truth, and then they start beating you. So we have to inform superintendent of hospital if at all it is there. We have to inform police station, and we have to tell them that send some constables. Something has gone wrong in our hospital. We have to keep our security guards with us. We can take help of our staff as well. They can guide also. They can guard us, and we have to keep emergency exit always open. If something goes wrong, we can take exit. While breaking the bad news, we will take some proper care before starting counseling regarding the bad news. We have to verify the patient and the medical data. Again, the same thing. You should not start speaking in front of whatever the relatives that have gathered. We have to confirm that we have to confirm that this relatives belong to this patient only. Again, we should take support of staff whenever possible. We should ask the family or members to be in a comfortable room. It should not be like that you go outside and in waiting room, 15 to 20 people are gathering, and there are some relatives of other patients that are admitted in the ward, and you start breaking the bad news that, oh, this patient has gone away and this has happened. And the rest of the relatives come to know, and they also get frightened. So it should not be like that. We have to make them sit in a comfortable private room. We should look like a professional as well. As we already told that we should be well groomed. Sometimes what happens is that we resuscitate the patient, CPR up, all the inserts and hairstyles and everything gets disturbed. So again, we have to redress in the sense we have to make ourselves proper so that we look like a professional, and then we go in front of the relatives.
Bhavik, time is overshooting, so you conclude, please.
Yes, sure, sir. We have to I'm just coming to the conclusion now. We have to break the bad news directly but compassionately. We should give family enough time to express, and we should be sympathetical towards the relatives. Relatives just want truth and nothing else. If you tell them the truth with proper sympathy, they will not harm you. These are two important things that you should never tell, and I want to tell this properly, that avoid blaming to the relatives. The moment you stop blaming relatives and you tell them that there is no fault of yours in this difficult time, they will also think that you are also not fault. So never start blaming them. अरे आ डॉक्टरे पहले रेफर कर दी तो साરું होत. તમારે पहले આવવાની જરૂર હતી. It should not be like this. Staff should not contradict your statements, and you should don't refuse for PM, always suggest from your side. I'm skipping many of the slides and just wanted to highlight one important thing from Foxy, and that is that Foxy has come out with indemnity policy scheme, and the scheme has coverage from 20 lakh to 3 crore rupees. And one more beautiful thing about this scheme is that it covers all the negligence or possible negligence done by your untrained staff also. So this becomes very useful, and everyone should take this indemnity scheme. Thank you. Thank you very much. Over to Dr. Dipesh.